So I'm not sure where I got the mix up. It was from my course calendar, but your colorectal cancer is going to be chapter 58, 1438 to 1448, with your gastric cancer being chapter 57, 1401 to 1404. So when we talk about our colorectal cancer, it kind of strikes home for me. I always think about Chadwick Boseman, the guy that played in the Black Panther, being so young, dying from something like this. Um, it's going to be your third most common cancer and the second leading cause of cancer death in the U.S. It's having an increased incident in your younger adults. Keep in mind it's more common in men, with your highest incidence and mortality being in black individuals. You use me. I'm so sorry, y'all. The book was talking about evidence-based type protective factors for your colorectal cancer. We're looking at high fruit and vegetable intake, regular physical activity, routine use of aspirin or NSAIDs, hormone replacement therapy, especially in your postmenopausal women. Some other things they have under investigation are folic acid, vitamin B6, calcium, mag, garlic, fish consumption, as well as medications. I'm sorry, statin medications. When we talk a little bit about your pathophysiology, it's going to originate in your glandular cells in the colon and rectum. Sometimes they can metastasize to nearby organs, spread in the lymphatic system or the bloodstream. And I think that's all I want to say about that part. We go on about our risk factors, one of them being family history. You have familial adenomatous polyposis or hereditary non-polyposis colorectal cancer, or even Lynch syndrome, the book mentions. Your patients with chronic inflammatory bowel disease like also ulcerative colitis. I'm sorry, y'all. I'm getting tired to and that's been greater than 10 years. Obesity with a BMI greater than or equal to 30. You got your high fat, red processed meat diets, smoking, alcohol, low fruit and vegetable intake, type 2 diabetes, physical inactivity. Um, as far as age, they talk about, after 50. However, remember your rates have been increasing for individuals under 50. I want to say your colorectal screening, your colonoscopies, they're supposed to be done every 10 years, and you start them at 50, I think. This is for your patients. I think the book said 50 to 75, but the slides in here later on, so we'll clarify that as we move forward. So your signs and symptoms that we look and seeing, your early signs going to be like unexplained weight loss, fatigue, changes in the bowel habits or stool appearance. One thing in particular, blood in stool, red or black. Abdominal pain, distension, feeling of incomplete evacuation. That could be signs of a tumor, signs of anemia, as well as intestinal obstruction as the tumor grows in size. So with this one, this is figure 58.7, and these are your tumor signs and symptoms based on the location. So when we look at like your key signs and symptoms, this is like your most condensed version of it. This is just another table from what we saw previously on the previous slide. We talk about our colorectal cancer diagnoses. Your gold standard is going to be the colonoscopy, of course. It's going to help visualize the colon, allow biopsies, polyp removal, and the screening is going to be based on your risk factors, not just the patient's age. Do they have a prior polyp history? Your other tools they call the CEA, the carcinoembryonic antigen, that will be elevated. It's like a tumor marker. You got your CBCs. We will be looking for things like increased white blood cells or either anemia. You also have the CT scan, the MRI, as well as the chest x-ray, and all of these can detect obstruction or spread of the cancer. This is your different diagnostic studies for colorectal cancer. Just wanted to um, make you aware of those. Don't go too far down in the rabbit hole. Just know these are some of the diagnostic tests for your colorectal cancers. So in box 58.3, this was a table, well, the box that I was telling you about that we will talk about later on. So it's 45 to 75. And these are your screening requirements per se. So we're still looking at like screening for a colonoscopy every 10 years. Stool-based tests, they have those options as well. So when we talk about our treatment, this is your chemotherapy, radiation therapy, of course. If we use them together, it improves survival rate. Recommended for your stage 2 and 3. It could be given intra-arterial, especially if you have liver metastasis. Your side effects are common ones: diarrhea, mucositis, leukopenia, mouth ulcers, alopecia, peripheral neuropathy. As far as your radiation, remember this is what's going to shrink the tumor. It gives you local and regional control of your disease. It's used palliative to relieve like pain, hemorrhage, bowel obstructions, lung metastasis. With your colon cancers, you have limited impact on survival. However, with the rectal cancers, it can be effective if used preoperatively, intraoperatively, and postoperatively. And that's just basically talking about your radiation therapy with your colorectal cancer patients. So as far as our surgical management, you got your colectomy, hemocolectomy, abdominal perineal resection. Your primary goal, of course, we want to remove the tumor and the margins of the tumor, excise the affected colon, liver, and nearby lymph nodes. The decision is going to be based again on tumor size, location, and stage of the cancer. A lot of it is localized, and the surgery a lot of times is curative. Other considerations, you're looking at these patients end up on colostomies. They can be temporary or permanent. If they are temporary, they come back and do anastomosis or a reconnection. And also, they try to have sphincter preservation possible with some of your rectal cancers. So with your colectomy, you're removing part or all of the colon. Hemocolectomy, removal of right or left half of the colon. Then you got the abdominal perineal resection. That's going to be removal of the colon, the rectum, and closure of the anus. This one here is pretty much a permanent ileostomy. Okay. So as far as our complications, metastasis is going to be your potential complication, of course. Especially when the cancer is more advanced when diagnosed. So you're looking at surgical complications. This patient could have blood loss. They could have leakage at the anastomosis site, infection with any surgery, incisional dehiscence. Some of your chemo complications, we're looking at fatigue, increased infection risk, anemia. With your radiation complications, we're looking at diarrhea, blood in the stool, weight loss. And of course, with advancement of the disease, you're looking at metastasis to the liver, the lungs, as well as other organs. So as far as your pre-op assessment and analysis, again, signs and symptoms associated with the location of the tumor. So think about this patient in the preoperative phase. We want emotional support. You got to recognize the impact of the diagnosis. We got to educate the family and the patient. We also have to have reassurance and clear communication of expectations. Um, you got to make sure that the patient understands the disease and the treatment. We're correlating symptoms and diagnostics with the tumor location. We're looking for things like weight loss, fatigue, blood and stool, signs of anemia. We also check this patient's support system. What kind of support do they have behind the scenes? A lot of your post-op recovery, you have to address those needs as well once the patient has a surgery and has to go home. These are your nursing diagnoses. So as far as our assessments, we're looking at vital signs. We want to make sure we have a good baseline. We look at the labs. We want those to be within normal limits. Your CBC, we're checking for H&H's for anemia, white blood cell count for infections, and we also reinforce understanding of surgery, drains, as well as recovery expectations for these patients. Um, Prior to, we look at bowel prep if they have to have it ordered. It's called polyethylene glycol. It's another name for it is go lightly, and you do everything but. You do pre-op antibiotics to reduce infection risk. And also remember, we got to build therapeutic relationships with these patients, build trust to ease anxiety. And of course, your consent forms have to be signed for sedation. Excuse me, as well as anesthesia and the procedure itself. Talk about the teaching of your patients with your colorectal cancers. You got ostomy care that you have to educate them on, as well as pain management. The biggest thing with the ostomy care, you got to make sure that you have your wound and ostomy certified nurse that is doing consulting and educating the patient prior to them having the surgery. Is going to reduce anxiety, improve post-op adjustments. Um, as far as pain management, of course, PCA. Epidural, oral meds. The biggest thing is just being able to know your options. This is box information from box 58.4. Ostomy care. It's in your book. So just for your overview, we know that a colostomy is the opening from the large intestine in the abdomen. Your ileostomy is going to be an opening from the small intestine if the colon has been removed. What we want to do with it, we're trying to divert stool into a secure appliance for elimination. We assessing that stoma. We want to make sure that it's red, beefy, pink, moist. Some of it can be mild and edematous, and that's okay. We want to report any type of dark, red, purple, swollen, the site of the stoma that's not supposed to be swollen. That's indicative of ischemia. If you have heavy bleeding, of course, that's hemorrhage. You want to notify the physician immediately. Keep in mind, we check the surrounding skin care. You know, you got leakage, so that could be a risk for infection. As far as maintenance, we're looking at the colostomy to begin working within 2 to 4 days after the surgery. Remember, we're watching out for gas, stool output. Empty that appliance when it's a third to a half full. Depending on where the ostomy is, depends on what type of stool you'll get. According to the book, initially the stool is liquid, and then it's going to vary by the location. Let's see. When it comes to that pre-op teaching about the with what the wound and ostomy nurse does, we look at things that we're going to do to improve outcomes. You mark the best area as far as the stoma site, and that's going to be an assessment of the patient lying, sitting, or standing. We talk about fears. We make sure we look at skin folds that the patient may have, any scars, as well as the appliance fit itself. I always give these individuals educational materials for self-care and success. Your figure 58.9, and it's stool consistency based on the location of the ostomy. Your this is 58.8, and this is going to be your common locations for your stomas. So when we talk about our assessment and analysis, again, safety alert. If the stoma begins to show signs of ischemia, dark red, purplish, or black color, unusual bleeding, notify the provider immediately. This is a sign of little or no blood flow to the stoma. Okay. As far as our post-op nursing management, we look at vital signs and compare them to the preoperative baseline. You look at consciousness and orientation of the patient, of course, pain control, CBC monitoring, especially when we talk about your H&Hs, we want to monitor. Being that they're post-op, you can expect some mild anemia. Increased white blood cells can indicate inflammation or infection, so you always want to assess that surgical site for signs of infection. Assess your bowel sounds. Initially, they'll be diminished or absent. They should become back to normal after the abdominal surgery. So as far, again, I reinforce the stoma should be pink, moist, and well perfused. With any abdominal surgery, you know it's going to hurt when they cough. Always talk to that patient about splinting with the pillow and holding their stomach whenever they do cough, and deep breathe with those exercises. Here are your nursing diagnoses. As far as your post-operative assessments, vital signs every 4 hours according to the book. As far as your temperatures are, you're looking at mild temperatures that can be normal inflammation, your high temperatures early on, possible infection or atelectasis. We got tachycardia, hypotension. This could be indicative of your fluid volume deficit. Your labs, H&Hs, we're monitoring for bleeding. Okay. WBCs, we look for signs and symptoms of infection. You know, it also reveals the inflammation process. So if it's early, if blood's taken early and it reveals that, you know, that means that it's a normal finding. But later on, if it's still increased, that could be indicative of infection. We look at GI function. We keep this patient NPO until bowel sounds return. What does that mean? Because at that point, the bowels have started back working. Your NG tube is for decompression. Always check your patency. Gradual diet advancement from clear to full to solids as the patient tolerates. We do eyes and nose. Remember, your urine output is greater than or equal to 30 mLs an hour. Okay. Foley care to prevent UTIs if they have those. Also, we want to prevent fluid retention that's common in early post-op patients. Let's see. I didn't say it all of that. With your ileostomies, and remember it's liquid, so you want to make sure that you're monitoring those electrolytes, particularly your potassiums. Assess pain regularly, and because we got to make sure that we're allowing this patient the ability to be mobilized, as well as help them with their healing process. As far as more post-op actions, we're looking at IV fluids to replace those surgical losses, NPO again until bowel sounds return, NG tube care, looking at the output, preventing obstruction, pain management, drain care. Sometimes they have Penrose drains, JP drains, Hemovac drains. We're looking at the amount of drainage, the color, and the odor. All of those things that was in y'all should have had in Med-Surg 1 as far as those drains are concerned. Pulmonary hygiene, don't know why they call it that, but that's what it's called. Turn, cough, deep breathe. Your IS 10 times an hour. Early ambulation, we're preventing blood clots. They will have patients, remember, as far as the standards of care, whenever a patient comes to the hospital, they probably have some type of DVT prophylaxis. That's your heparin or your Lovenox. Be careful with your post-op patients as well. when it comes to giving blood thinners, so just keep that in mind. Perianal care, we're looking at sitz baths, monitor for any type of abscess or phantom rectal pain. We also make referrals. Remember, taking care of a patient is holistic. We have interdisciplinary care. So you got social workers, home health, as well as ostomy support groups. So in your post-operative complications, remember we want to teach them early, and a lot of times we want to do this before pre-op. With your ostomy care, this is where, again, we're talking with the wound and ostomy care nurse for that hands-on teaching and that support. This is the last slide in this presentation. Y'all already know how to contact me. I will see y'all during the next class session. Let me know if you have any questions. Thank you.